So I'd like to welcome you all to this month's Canadian Cancer Survivorship Research Consortium round. This is Jennifer Jones. I'm here at the Elixir Boardroom in Toronto, and I'm going to be moderating today's session. So I'd like to thank those of you who have joined us remotely. We're here in our boardroom with a nice full boardroom, so we're really looking forward to the talk. Today, just like our usual format, we're going to hear from our speaker, and then we'll hopefully have some time at the end where we can open up the floor for any discussion or questions that you might have. I just do want to remind people to please mute yourselves during the presentation or when you're not talking, just so we don't get any feedback, and also to remind you that this is going to be recorded. So I'd like to now introduce our speaker for today. Our speaker is Dr. Sophie Lebel, who is going to be presenting on recent advances in fear of cancer recurrence research. Dr. Lebel is an associate professor at the University of Ottawa in the School of Psychology and also a clinical psychologist. Her research focuses on cancer survivorship with a special focus on fear of cancer recurrence, stigma, sexuality, didactic adjustment, and fatigue. She is very well published and presented worldwide, well-known expert in this area. Dr. Lebel is also the current chair of the Special Interest Group on Fear of Cancer Recurrence with IPOS. So, Dr. Lebel, I will pass it over to you, and thank you very much. We're looking forward to your talk.
Thank you, Jennifer, and thank you for having me. It's a pleasure to be here with you today. So, as the title indicates, this presentation will focus more on research aspects about work on fear of cancer recurrence. If you do have questions about more clinical implications, I'd be happy to take those at the end as well. So, as I get started with the mouse here, I'd like to first acknowledge the collaborators that have made this work possible across Canada and internationally. Here's what I want to cover with you today. So I'm going to give you a very brief bit of background on fear of cancer recurrence. As I imagine most of you are familiar, at least in some bit, about the topic, so I just want to review some brief points. And then I want to focus the research developments by looking at an outline of a proposed research agenda that was set in an international colloquium on fear of cancer recurrence in 2015. So it's a 3-year-old agenda, and I want to cover the following points that are here and see how we've improved or where we're at with each of the, I guess, objectives that we had from this colloquium, and I'll go over each of one of these. I'll briefly conclude what we know so far and where I think we're heading, and hopefully this leaves about 20 minutes for questions. All right, so here's the brief background. So fear of cancer recurrence is now frequently defined as the fear, worry, or concern relating to the possibility that cancer will come back or progress. Most authors agree that the fear is a multidimensional phenomenon. At its core are probably emotions and cognitions, but you also have behaviors and phenomenon like over-focusing on body sensations that make up fear of cancer recurrence. As you probably are well aware, this is a very frequent phenomenon, a very frequent experience of cancer patients and cancer survivors throughout the cancer trajectory. We think of it as a continuum, so it ranges from normal to clinical and excessive. And normal fear in this context would be a cancer survivor that once a year, let's say around time of their annual visit to the cancer center or their family physician, and they're awaiting the result of some diagnostic test, experience a bit of butterflies and anxiety about what the test results will show, but other than that are not really thinking much about the cancer coming back. Clinical and excessive will be one of the things that I'll be talking about, so we'll have ample opportunity to talk about what that means. But basically, it would be a level of fear of cancer recurrence that starts having an impact on their functioning or is accompanied by excessive psychological distress. Now, our best estimate in terms of prevalence of this phenomenon is that about 1 cancer patient out of 2 reports at least a moderate to high level of fear of cancer recurrence, and these are results based on a couple of systematic reviews. And moderate to high level would mean that this is the level at which we start thinking that these patients should be seen for additional psychosocial services. So they're reporting at least some impairment and some distress, and most likely would benefit from some support. This will not come as a surprise, but there's now a great body of research that shows that fear of cancer recurrence is related to worse quality of life, greater psychological morbidity, most often looked at in terms of anxiety and depression symptoms, but as well as PTSD symptoms, and increased use of healthcare resources, and overall a sense of a lack of trust towards the medical system, that they will pick up the recurrence, and more dissatisfaction and more informational needs. All right, so in 2015, together with others, I organized a colloquium of experts in Ottawa to talk about what we knew about fear of cancer recurrence at that point, and try to organize ourselves and set up a research agenda. Here was the impetus for doing that. We noticed that there was a growing interest in fear of cancer recurrence research. Instead of looking at a number of publications in the past few years, I thought I would look at just one subtopic, which is randomized control trials for fear of cancer recurrence intervention. So you can see that prior to 2007, there had been no published interventions on fear of cancer recurrence, never mind RCT, but just a published intervention. And then we went from 4 RCTs in 2010 to 11 RCTs just in the past couple of years, and that doesn't include everything that's been published in 2018. So clearly this is a topic that a lot of people are interested in and are working on. So in 2015, we were 12 clinician researchers, 10 trainees, 1 representative of a government-funded cancer survivorship organization, CPAC, and 2 patient representatives together for a couple of days to determine research priorities. So we came up with 6 objectives, which were introduced to you at the beginning of the talk, but I'll name them again. So our first objective was to agree on a definition and on the diagnostic characteristics of clinical fear of cancer recurrence. We were interested in measuring clinical fear of cancer recurrence and think about what to do next. We also set as a priority to create guidelines in the use and implementation of fear of cancer recurrence measures in a clinical setting. We focused also on, we said the focus would be on elaborating and or refining theoretical models. And then we had some proposed next steps for interventions, which I'll describe. And we also had an interest in formally structuring ourselves, us people interested in working on fear of cancer recurrence research, as a group. So, how did we do in the past 3 years in terms of all these objectives, which we saw as the top research priorities? So, the first objective, which was just to agree on a definition, as there were various definitions of fear of cancer recurrence or fear of disease progression floating around, we came up after 3 rounds of discussion of everybody that was at the colloquium. We used a Delphi study, and we came up with the following definition. It's fear, worry, or concern relating to the possibility that cancer will come back or progress. So each of those words were debated very carefully to reflect the fact that sometimes we're talking about a real concern, a real fear. And sometimes we're going towards more of a worry about acknowledging that sometimes there's a very strong chance that the recurrence will happen, and sometimes there's a much less greater chance of an actual recurrence, but people are nonetheless excessively preoccupied. This is relating to the possibility. So this is a real possibility. It's anchored in, in reality, that the cancer will come back or progress. Those 2 were important as well. Come back for people, let's say, with solid tumors who would experience the recurrence as a new primary or as an actual recurrence of their cancer in an organ, or progress for people who have stable cancer. So we're thinking of, I guess, some lymphomas, leukemias, where they are never considered in remission or cured, but what they might be concerned with is their disease progressing and deteriorating. So we wanted a definition that would include every cancer survivor. All right, moving on to the second part of this objective, which was to agree on clinical features of fear of cancer recurrence. So as I mentioned, you can have a normal range of fear of cancer recurrence, but sometimes it becomes a problem that's worthy of attention. And right now what's happening still today in the field of fear of cancer recurrence research is that without an agreement on what those clinical features are, it's very hard to measure clinical fear of cancer recurrence accurately. So we end up with estimates of severity of clinical fear of cancer recurrence that range from anywhere to, let's say, 10% to, I've seen a paper that identified 70% of its participants in melanoma patients as having likely clinical fear of cancer recurrence. So obviously there's big implications for research, for access to services, and for the possibility of stigmatizing people. So obviously this is an important topic. So at the Colloquium in Ottawa in 2015, we came up with 5 core features that we thought would be potential candidates. But we hadn't formally asked we felt like we needed to ask a wider group of experts if they agreed that these were the essential features. So in order to do that, we set up to conduct a Delphi study of international experts on this topic, just to determine what are the features of clinical fear of cancer recurrence. And this study was conducted in 2018 from January till June by a PhD candidate that I supervised. Her name is Brittany Mutzers. So she conducted 3 rounds with 65 international fear of cancer recurrence experts. And participants were asked to rate features, starting with these 5 features, and they could also suggest additional ones. And they were asked to come up with features that should be present to either identify or diagnose clinical fear of cancer recurrence. That was important because most researchers and other professionals might not be able to diagnose, but they're able to identify patients. And we actually even asked them, do you think this is a good idea? Do you think it's a good idea to identify clinical fear of cancer recurrence? Do you think it would be a good idea to diagnose clinical fear of cancer recurrence? And since we're talking about diagnoses, we felt like some of the existing DSM-5 or ICD-11 diagnostic criteria could be relevant. And there was quite a close relationship, so we asked them, if you were to give somebody a diagnosis, would you feel comfortable using these diagnoses that already exist? And in order to say that we had achieved consensus on a feature, at least 65% of participants had to rate this item as an 8 out of 10 in terms of its acceptability. So in terms of results, what we found is that all participants believed that it would be helpful to identify cancer survivors with clinical fear of cancer recurrence. 84% of participants who could communicate a diagnosis, so this was a subsample of the 65 international experts who could diagnose, indicated that it would be helpful to be able to diagnose clinical fear of cancer recurrence. And participants did not support the use of pre-existing DSM-5 or ICD-11 criteria. They felt that these criteria did not capture the experience of clinical fear of cancer recurrence. Hence, we also decided then to propose some features of what clinical fear of cancer recurrence is. So here are the results. These are tentative, strongly tentative results, as the final results will be presented at Cano in October by Brittany. So we found that in order to identify fear of cancer, clinical fear of cancer recurrence, the following 2 features must be present. So there must be persistent worry, fear, or anxiety, as well as hypervigilance or hypersensitivity to bodily symptoms. So that would be a cancer survivor who's frequently monitoring their body for signs and symptoms and tends to interpret their symptoms as a benign headache, for example, as a sign of a brain tumor. In addition to those 2, you have to have at least 2 more. So we're saying that in order to meet potential diagnosis or to be identified as having clinical fear of cancer recurrence, you need 4. So 2 of the following must be present as well: high levels of preoccupation, high levels of worry, impairment in functioning, difficulties making plans for the future, and presence of at least 1 maladaptive coping strategies, and we would list them. Most of them are about avoidance, either cognitive avoidance of places or people, of reminders basically of the cancer experience, and or excessive reassurance. That could be excessive checking online, for example, and excessive use of internet. And we said that these characteristics must be present for a minimum of 3 months in order for this to be a recognizable entity. So that was for objective 1. The next logical step, once we've conducted this Delphi study, was to now talk about how to measure clinical fear of cancer recurrence, now that we seem to have agreed about what it could be. So following the results of the Delphi study, a gold standard interview will be proposed and tested. So that's kind of part 2 of Brittany's doctoral thesis, is to come up with a semi-structured interview that will be pilot tested. So this means a very significant revision of the current proposed gold standard, which is an interview, a semi-structured interview that was developed by Simard and Savard and used in a couple of studies. This interview, the previous interview is based on the DSM-4 SCID. It's got 18 questions on various aspects of fear of cancer occurrence, such as content, frequency, duration, triggers, emotions, insight, functioning impairments, and coping strategies. So some of these questions apply to the proposed criteria of clinical fear of cancer occurrence, and some don't. So if you're curious about what insight means, insight was asking cancer patients during the interview if they felt like if they were aware that their preoccupations were excessive. And most of the patients that we ourselves interviewed in my lab had a hard time answering this question because they felt that their preoccupations were very realistic given their chance of the cancer coming back. So they had a hard time with this question. So there needs to be a significant revamping of this instrument that was also based on identifying people based on excessive distress, impairment, functioning. So that part we will probably keep. So this is going back to that. So that's work that's going to happen next, and then authors will be also encouraged to take the proposed features of clinical fear of cancer occurrence and then try to apply them to instruments, which is what I'll talk about. So pencil and paper-based questionnaires, if you want, self-reported questionnaires. So in terms of the objective 3, which was discuss the use of fear of cancer recurrence measures and see how they could be applied in real-world setting, the colloquium had 2 objectives. We said that we needed to conduct we need to update our systematic review of fear of cancer recurrence measures, focusing on recommendations specifically about measures to use for screening, case-finding intervention purposes. As you'll see in the next slide, there was a systematic review conducted, but it was in 2012. It was getting a bit old. And we also outlined a second objective in that colloquium in 2015. It was to develop cross-culturally valid short screening instruments and longer instruments that would reflect the new definition of fear of cancer occurrence, as well as clinical fear of cancer occurrence. And we said that including a range of respondents, such as caregivers, cultural language was seen as a priority. So now I'll tell you how we've done. You can see for the first part about the updated systematic review, this is currently being done and led by Dr. Christine Mary from McGill University and Dr. Belinda Tooze in Australia. So they're in the process of updating the systematic review. So which means that I'll talk about what we know from the older review published in 2012. Back then, 20 measures were identified, and I think a year after, another 5 to 10 newer measures were identified. So there's a lot of choices out there for people interested in measuring fear of cancer occurrence. The authors of that review said there were several valid and reliable longer measures, so we're talking about 10, 20, and more items. And they name a few, such as the one that was produced in Canada by José Savard and Sébastien Sivard, the Fear of Cancer Recurrence Inventory, the FCRI. But there were few brief measures with sound psychometric properties based on that review. And then there was limited demonstration of predictive validity. And this is something I'll get back to. So there's a lot of measures out there, but we don't quite know how to use them to reliably identify clinical fear of cancer recurrence. So what is the cutoff score that you should be using? Most of these measures don't have a cutoff score. So how do you use them to identify the people most in need? As I said, part of the problem came from the fact that we didn't agree on what to look for in terms of clinical fear of cancer recurrence. Then part of it is the fact that most of these measures were not designed to have a cutoff score and then to reliably identify these people. And then that review identified a lack of cross-cultural validity, as measures tended to be developed primarily in English, but not adapted to other countries. So in terms of how we've made progress in the past 3 years, sadly, available measures are still not being routinely used by oncology centers to assess fear of cancer occurrence among patients. So as far as I know, no oncology center around the world is using a fear of cancer recurrence screener in a systematic fashion as part of routine care. There are some brief measures that seem to have really good psychometric properties, and that could be promising for fear of cancer recurrence screening. They have 4, 7, and 6 items. So I've left you with references because I know you have access to these slides. So in the absence of an instrument to recommend, what I often do and others do when we recommend the use of measures is we say, well, we recommend that you follow the only published guideline available to date that was published from Cancer Australia. Fortunately, it's getting also a little old. I think this was also in 2012, so it would benefit from some updating. And in this guideline, you'll find some excellent questions to use to ask cancer patients if you're interested in screening. So they list questions that you could ask to probe for the presence of fear of cancer occurrence, the frequency, and the severity. So in the absence of reliable measures that have proven to work in real-world settings, I would recommend that you use these clinical guidelines. Of course, it was, here's an opportunity for me to say that I think we should make efforts in Canada to publish similar guidelines, as thus far we have to rely on older guidelines. In terms of how we've done with cross-cultural validation of instruments, so I would say that the instrument that's probably most often used right now is the Fear of Cancer Recurrence Inventory, the FCRI. It's been validated in several languages that I've listed here, and there might be others that are other cross-cultural validation that are ongoing. So often people will use this instrument, and it's a multi-dimensional instrument. There have been some studies, one conducted by myself, one conducted by Jacqueline Galicia from Queens, to try to replicate its 7-factor structure, and we found that in overall this instrument does have 7-factor. Jacqueline Galicia also actually compared a 1-factor, 2 factors versus 7 factors, and found that the 7-factor structure is still the best. So this instrument has got satisfactory psychometric properties, and its full version, it's quite long, it's 42 items, so it's not something you would use routinely in clinic. There is a 9-item short version that is frequently used to identify people with clinical fear of cancer recurrence. The problem is that its cutoff score is being debated right now. Originally it was proposed to be 13, and several studies finding it probably too low to reliably identify people with the highest need, and some suggesting that the cutoff should be raised to 22. So again, it leaves you with quite a bit of uncertainty to identify people with clinical fear of cancer recurrence. So we hope that with a better definition of what clinical fear of cancer recurrence is and some criteria to identify it, this will lead to instruments that can more reliably identify clinical fear of cancer recurrence. And again, there's some authors that have found that the FCRI probably has some item redundancy with its 42 items, and that a next proposed step that the main author, Sébastien Simard, is also looking at is sort of cleaning up the instrument and coming with a more streamlined version. Here's my favorite part, where we're going to talk about models of fear of cancer recurrence. I love models, but they can often get confusing. So I will talk now about the 4th objective of the Fear of Cancer Recurrence Colloquium, which was to refine or test existing models or parts of models. Sorry, there's the header missing at the top there. The header should read Objective 4, which is refining existing theoretical model. And in here, I've added for your reference a really great article that's sort of a summary of models of fear of cancer occurrence, and they propose a model that combines various models. It's a very interesting read if you're interested. But these authors already had identified 6 different models of fear of cancer recurrence and reviewed them. So that's a lot of choices, again, for researchers and clinicians in terms of drawing upon available resources. I should say that most of the described models have not been empirically validated. So they've been proposed. Some relationships in the model may have been tested, but in general, we have a lack of testing of these models. So there have been, in the past couple of years, attempts to do that, to propose models that inform interventions, test those, and propose, future avenues for research. So a model that I quite like comes from a team in Australia led by Phyllis Butau. And she and the team involved here have proposed a model that looks at metacognitive therapy. So for those of you that may be familiar with that, metacognitive therapy is becoming quite popular in clinical psychology. It's how are people thinking about their thoughts and how are people thinking about their emotions. And the key part I'd like you to see in this slide here is the one that's right below heightened fear of cancer occurrence. It's called problematic style of information processing. So this says that cancer survivors with high fear of cancer occurrence tend to engage in worry and rumination, and that one of the reasons that they engage in this sort of negative thinking style is that they have unhelpful beliefs about the importance, the impact and control of worry, what they call metacognitions. So if I worry about cancer coming back, I will be prepared for it. Or sometimes people will think, if I worry about cancer, then I'm more likely to make it come back. The authors are proposing that it's these kinds of thoughts that are sort of producing a loop that are maintaining some of these intrusions. So their therapy, which I'll talk about a bit, was targeting these kinds of unhelpful thinking traps. And they were also looking at biases. So they were thinking that people with high fear of cancer recurrence have almost a perceptual bias to look for information that confirms that they're at risk of having a cancer recurrence. So a lot of it is about shifting your attention to something else and training yourself to shift your attention. There seems to have been a little less evidence for that part of the model, but there's quite a bit of support now that's become available to say that metacognitions are an important aspect of fear of cancer recurrence and something that should be addressed. And interestingly, metacognitions have been found to be important across a range of clinical disorders like generalized anxiety disorder, depression, social phobia, and so on and so forth. So it looks like it's an important phenomenon for mental health. So why not create another model since there are already existing models out there? So ourselves, together with colleagues from Princess Margaret Hospital and Christine Meyer from McGill University, we've come up with our own theoretical model that is the base of an intervention that we've been working on now for a number of years called the FORT intervention, which was first pilot tested, and now we're analyzing results of a randomized control trial of this group intervention. I won't talk about it today as Christine will be presenting some preliminary results of the FORT intervention at Cano. But this is a theoretical model that influenced our intervention. So you'll see there's some similarities amongst models. So ours was looking at internal and external triggers. So these could be pains and aches, as mentioned, physical symptoms that act as internal triggers. External triggers could be finding out that a friend has cancer. It could be going back to the hospital. It could be hearing about Run for the Cure on the radio. So these are the external triggers. So we're saying that once people are triggered, they feel at greater risk of the cancer coming back. So all of a sudden they feel like, wow, there's a 100% chance that my cancer is going to come back. This feels very real. This leads then to what we call fear of cancer recurrence. So those emotions, those worries, those coping strategies. Once people feel like, they start having those thoughts about the cancer coming back, they have to cope, they have to do something. And what our model says is that people will frequently engage in what we call maladaptive coping strategies, such as excessive body checking, reassurance seeking from loved ones, or healthcare professionals, avoidance, I've talked about, excessive searching online, that these strategies in turn will feed into their fear of cancer recurrence. They may work in the short term, but in the long term they'll increase fear of cancer recurrence. So this was a model that was already, so that part was kind of fairly well established in the literature. What Chrissy Meyer and I added is a couple of other models. One is the theory of uncertainty in illness, where we say that when there's more uncertainty around what the survivorship follow should look like, who should be doing the survivorship, what kind of tests should people be having, what symptoms should I be looking for as a cancer survivor to know that my cancer has come back, we feel that in circumstances of uncertainty, it's more likely that patients will report that they'll interpret these triggers as proof that the cancer has come back. So it sort of acts as a moderator, it exacerbates that relationship. And then we added 2 pieces about cognitive models of worry. So this is similar to the previous model. We're saying that positive beliefs about the benefits of worrying. So if I worry about my cancer, I'm more likely to prevent it. So we're, like the previous model, saying that these beliefs are important. We didn't include the negative beliefs. So my worrying is dangerous, or if I worry, my cancer will come back. And we added another piece which is called Intolerance of Uncertainty. So really the difficulty living with the gray zones. That again is something that patients with a range of psychological disorders have. So this here was our attempt at validating this model. So we tested the model, and the participants who completed the randomized control trial using their time 1 data, so before they had the intervention, and I won't talk about it in great deal. You can read about it here if you want to ask me questions, but basically we found support for most of the relationships in the model, suggesting that this is, again, an alternative model that you can use if you're interested in working or applying some of these relationships with patients, or testing some of these relationships in future studies. So moving along to our before last objective, so objective 5, next steps for interventions. At the Colloquium, we said, well, we need to write up a review on the existing interventions. So we saw that there was a growing literature on fear of cancer recurrence intervention, some of which was accessible, some a little less. So we said, let's pull the data together. So I'm happy to report that this is happening, and I'll talk about it in the next slide. And then we also said that, okay, there are more interventions happening, but we need to focus on the following 3 priorities. We needed to test if tailored interventions, so if fear of cancer recurrence specific interventions are more effective than sort of a generic intervention, or generic support group, or generic mental health or distress intervention. We need to study the effect of couple or family-focused interventions on fear of cancer recurrence, or even on caregivers. And then to study the possible negative effects of fear of cancer recurrence interventions, as most interventions were omitting to report negative impact. So if somebody gets worse, that usually was not mentioned in previous literature. So I'm happy to report that I was part of a group led by a team in Denmark that is doing just that. So they're finished doing a systematic review and meta-analysis of existing fear of cancer recurrence intervention. And these results will be presented at IPOST next month. So they found 23 randomized control trials and 8 uncontrolled trials, most of which were what we call traditional CBT or third wave CBT, mindfulness or ACT. So I won't present those results, but they'll be coming up very soon, and I suspect that based on having seen some of the tables, that they'll show that most interventions are effective at reducing fear of cancer recurrence. So that means that there's a lot of possible interventions out there, and the meta-analysis will also try to see what are some of the common ingredients among these different therapies. In terms of the other objectives that we have set forth, I guess they're to be determined. As far as I know, we haven't made great progress in these different sub-questions. The first one I think is really an interesting one. I was recently sitting on a thesis defense of a student at University of Regina, and she had tested an intervention online looking at a general mood and anxiety intervention online for cancer patients. And she had a very brief one-session module, fear of cancer recurrence, and she found a significant reduction in fear of cancer recurrence, having a fairly generic CBT intervention for mood and anxiety that was, somewhat comparable to other effect sizes that have been reported by more specialized fear of cancer recurrence intervention. So it raises the point of, do we need such a level of specificity, or would people benefit from something broader? All right, in terms of additional research questions, I wanted to propose to you some potential avenue for research. We currently don't know what is the best mode of delivery. I doubt that there is a best mode for everyone, but nonetheless, it's always interesting to know would group work as well as individual, for whom. How about internet delivery? There are several ongoing trials that propose to deliver the interventions that already exist, but in an internet format. So would that have the same impact? Would it have as strong of an effect size as face-to-face? We don't know yet. What about real-life implementation? So now we're looking at about a decade worth of fear of cancer recurrence research showing that it's a high priority. It usually comes up as the top unmet need of pretty much any kind of cancer survivor across the disease trajectory. We have treatment, evidence-based treatment, but as far as I know, there are very few centers that are offering these kinds of treatments as part of routine clinical care. So what would it take to then implement such treatments in real life? What about a step care approach? So most of the interventions that I've talked about and that will be covered in the review are designed to address the needs of people with a high fear of cancer recurrence, so that clinical range that we talked about. But what about those that have sort of low to moderate? So that could be people that a few times a year may be preoccupied, but it's not having an impact on their functioning, but they might still want some help. So what should we do with people like that? And a possibility here is an intervention that I've cited called the Mini After C, which is basically a single session of 30 minutes CBT-based intervention delivered via phone by a nurse specialist. Yes, I should mention also that most of the interventions cited so far are quite costly because they're offered usually by one or two highly trained psychologists. And then people are starting to wonder, well, could these interventions be offered by other healthcare professionals, perhaps as part of a step care approach? And the pilot study of this one-time nurse-led telephone intervention found so far, a tentative improvement at reducing fear of cancer recurrence a week later. So I think this was just a very preliminary pilot testing on 16 breast cancer patients, but perhaps it's opening the door to test interventions that are delivered by someone else than expensive and highly trained clinical psychologists. So the last objective, so we wanted to, structure ourselves and try to, facilitate collaboration. So there's been a new, we created shortly after the Colloquium 2015, something called Forwards. We are the official fear cancer recurrence special interest group of IPOS, as Jennifer mentioned in the beginning. We have over 50 multidisciplinary members from all over the world. I'm currently in my first year as chair of this committee of a 2-year mandate, with my co-chair being Ben Smith from Australia. Our aims are to stimulate international and multidisciplinary research on fear of cancer recurrence, promote educational activities for members related to fear of cancer recurrence. So if you were interested and you were a member of IPOS, you could join our SIG and have access to tables that describe various measures, table of resources that are available online for fear of cancer recurrence for patients, as well as shortly a table that describes all the interventions that are part of the meta-analysis, as well as the links to these interventions. And we're interested in, of course, disseminating new research on fear of cancer recurrence. So we are on Twitter. So if you want to follow us, here is the link to follow us. And some of our members are posting regular updates about fear of cancer recurrence research. And since I'm here and I've got control of the panel, I will then now shamelessly plug our upcoming activities. So we will host our annual face-to-face general meeting at IPOS on November 1st. There will be a link posted on iPost and available via social media. We have the capacity to be live, so for people who were not able to attend iPost to connect remotely. So we did that last year when it was in Germany, and it worked well. So if you're interested and you're curious, you can join us. We will be circulating a link, and people can attend. It's a half-hour meeting talking about fear of cancer recurrence, and we'll be presenting 2 symposia. So to conclude, fear of cancer recurrence is a very rapidly growing field. My personal take on this is that in the next few years, research efforts should focus on developing brief screening tools. We're talking about 10 items or under, or even perhaps a 1-item screener. I'm even curious about how the anxiety question of the ESAS would do as a screener for fear of cancer recurrence. That would allow the reliable identification of cancer survivors with clinical levels of fear of cancer recurrence. We need to identify commonalities among models, perhaps also to identify commonalities amongst interventions, identify the key ingredients of interventions, and really examine, are there people that are negatively impacted by these interventions, just so that people can make an informed decisions. We need real-life implementation efforts of interventions to make these treatments right now that seem to work well accessible to clinicians and to patients. And I think, particularly for us in Canada, I think we could work on our knowledge translation efforts to educate, for example, primary care physicians about what fear of cancer recurrence are, our oncology colleagues, reaching out to patients, patient support groups, having more dissemination efforts, and, you know, of course, having our own guidelines would be a very welcome step. All right, I'm leaving you with some resources of some articles that I've mentioned. So they're there for you to consult about different topics. And now I'd be happy to answer any questions you may have.